discussions. So the first case is by Dr. SM Ajoy. So Dr. Ajoy, could you please start your presentation? You already are sharing your screen.
Yes, I've been. Okay, so with regard to the, yeah, I'll do that. But just before that, one thing with regard to the custom orthosis, we do have a limb center here in the hospital where I work at. So the custom orthosis, we make it as cheap as 2,000 rupees. So which is probably like $3 or $4. So
Must be cheaper. Must be cheaper than the off the shelf ones
over
here.
the, yeah, off the shelf ones.
I will send my
So
patients to you, Ajoy.
yeah, I think that would be good. If you just send us the mounts, then we could probably make them and send them back to you.
Wonderful.
Okay.
Thank you.
Okay. Now, this case is actually, it's probably going to open up Pandora's box, but then it's not actually something like what you would call an adult acquired flat foot. It is a patient who is complaining of pain in the knee. So this is what he is. So it's just a 37-year-old male who was complaining of pain in the knee. So this is exactly the scenario which you said does happen. He was complaining of pain on the medial aspect of the knee. He also had some amount of medial foot pain. And when he did come to me, he already had all his MRIs done. And the MRI was showing that there is some tibialis posterior tendinitis. And of course, he had a pes planus like this. So this is what he was looking like. So the right side is the side which he is having pain.
Yeah.
And of course, he was unable to perform a single heel raise. I just told him to do it, and he said it's just not possible.
This is a great picture, Ajay. Sorry to interrupt, but you can see what is happening to the calf muscle. You see the calf muscle completely wasted on the right side.
Yes.
You can see some fullness. You see these, just like olecranon fossa, just like the knee. In front of the knee, you have this nice little fossa around next to the tendon. Nice little fossa on. If you look from the back of the elbow, nice little fossa. Same thing. You should be able to see nice little concavity on either side of the Achilles tendon. On the left side, you see that. On the right side, you don't see that. Right? So there's some fullness on the medial aspect of the ankle. So there must be something inflammatory going. Yeah, right there. Right
exactly
there.
that.
Exactly right there.
Okay.
Yeah.
Okay. So this is how we presented with. So apart from the routine X-rays, of course, we did the Salzman view. So this is what I could obtain. So not a excellent view, but then at least we could see that the alignments, you can see this is the tibia which is going down this way and the calcaneus which is aligned this way. So choice of procedures, so probably something to do with the calcaneus. I think medial displacement osteotomy would be in place in addition to doing something on the medial side. Would that be right?
Yes, I think, well, I mean, let's everybody weigh in then. Let's see what others do. It's a good case. It's this kind of case we see often. So is there a lateral X-ray at all, weight bearing?
There is a lateral X-ray, but I haven't put it up because I said nothing much apart from the standard things were there. So I thought, for the sake of saving time, I said we'll just show only these things which would probably make a difference to
good
deciding on the treatment.
Do you want me to speak, or you want other folks to weigh in?
Anybody. So I think it would be best if you could tell us. So would just a medial displacement calcaneal osteotomy with some intervention of the tibialis posterior, like say a dibrima and FDL transfer would be sufficient, or should we plan anything more in this case? Like something.
Sir, I would like to know about the standing AP of foot, so know the lateral column and talus uncoverage.
Okay,
so that do we need any lateral column lengthening or something?
That's right. Yeah, Aditya is right.
Okay.
You want to see what's happening in the AP, what's happening in the lateral view.
Okay, so I just didn't put them in. So
No
there
problem.
wasn't much of there was not much of this thing which was happening. So this is what I went ahead to do. I'll just show what I did for this. This is the medial side when he explored. So that's the tibialis posterior which is there. So it was having a very, very thickened tibialis posterior there. The whole of it was intact, and there was absolutely no tears or anything. There was just this very minimal bit of some synovitis were there. But apart from that, his tendon was quite good. And I looked it around everywhere, nothing at all. And then he had a huge hypertrophied tendon. So do you see this kind of a thing very often?
Ajoy, that
Yes.
is a area of degeneration, you see. So it may look intact, it may not be a line like a longitudinal tear.
Okay.
A normal tendon is a shiny, glistening structure. So if you see
Okay.
a whitish area, what we call as a crab meat, like a cooked crab
Okay.
meat,
Mm-hmm.
whitish, dullish area, that is a degeneration. That is the area of degeneration. So you have to exercise that. Exercise that. Otherwise, there's a pain generating area, just like in Achilles tendon, just like in any other tendon. That whitish, like a chalk, not almost chalk, but it has to be shiny, glistening tendon. If it is not shiny or glistening,
Mm-hmm.
that means there is a degeneration. That means you have to remove that area, dullish area, and if
Okay.
you cut on it, you see, it doesn't. There's a different consistency also. So
Okay.
that tendon is degenerate. That is a degenerate tendon.
Yes.
Okay.
So, Panchmabi sir, if I may ask, if you are encountered with such a diseased tendon, tibialis posterior, so what do? You do an end-to-end resection and end-to-end repair, or any other thing?
This is where our basic pathology comes into play. See, so when we showed the tendon area of degeneration, see, so the inner aspect of the tendon is hypovascular. Outer aspect is okay. That's why you don't see many tears on the outer surface. You see the tears in the inner surface of the tendon. So again, depends if it is so far gone that entire uh, width of the tendon from the medial to lateral, which is very rare. So sometimes just the medial third, which is gone. We just need to excise that.
Okay.
And you can save the tendon at that stage. So this particular patient has come at a very early stage. But again, Ajoy is hiding those AP X-rays and lateral X-rays. That will also help us in, so if there is a change in that also, so then you need to think about shortening the tendon, do an end-to-end kind of, take up the slack, as it were. But if the AP X-ray shows there is no uncoverage, you can say, well, I'm just going to excise this. I'm going to medial shift the heel, and that will work. That will work because your tendon becomes shorter, and the Achilles tendon also helps the posterior tibial tendon. Just doing medial displacement osteotomy and debridement will be effective in certain scenarios as long as the forefoot is not affected.
Okay. So not much of abduction at the forefoot. I think that these
Yes.
are the conditions where this alone should suffice. Okay.
Yes.
So this was on the lateral side. I just did a lateral calcaneal osteotomy, a medial calcaneal sliding osteotomy, fixed it by means of a plate. A 7.5 shift was what I did, and this was the poroperatively. So this is what we can see. You can see that this calcaneus is very well aligned with regard to the tibia here. So I was able to get this much. And there's something else which I did. I put in an EOTTS. So this is an extraosseous talotarsal stabilization. So one of the things that they say that if we are able to lift up the talus, so normally most of the pathology which happens is because of the whole of the talus which is kind of shifted medially and is out. So that through the acetabulum pedis, it's kind of shifted out. So if you are trying to lift this up on the medial side by just putting in a stent like this, then probably you should be able to get most of the alignment correctly. One of the theories
Ajay,
which is
like you said, you wanted to open the Pandora's box. You have done that
yes,
very successfully here.
yes,
Up till now, there was no problem. Now there is a problem. Now
yes,
there's a problem. So
yes,
that's
sir.
the controversial area. See, so
Okay,
what you're doing is a subtalar arthroresis.
Arthrolysis.
Arthroresis,
yes,
and you could argue, I could have just done that instead of everything else. Why did you do a calcaneal osteotomy? You could just do that arthroresis without the calcaneal osteotomy. If you're just looking for correction
okay,
in subtalar joint, you could just do that and get that tilt back, you see. So but that is not very well tolerated in adults, you see. So in kids, I do that, and I do that again. We talked about adolescent flat foot and kids who might grow up with a dysplastic bones, you see. So you sometimes see severe deformity in the kids, such that you can, oh my god, what's going on. When you take a lateral x-ray, the medial cuneiform is lower than the fifth metatarsal, so you can see there. I do not mind using that. I have used quite several times this thing, and the kids really tolerate it very well. They have no problem in tolerating. They are happy. They don't need to wear shoes inside outside home. They can be barefoot and they can be running, and the bones there are growing in a normal environment, normal forces, normal musculoskeletal forces, and then they will grow into a normal length. You see, so lateral column length will be normal. And so that's why I really have no hesitation in recommending these subtalar implants in kids, childhood, growing up to maturity. But in mature adults, you see, so that is like kind of something into a joint. Some people actually have removed quite a few of them. That's what I'm saying. Is it a temporary phenomena for you or permanent phenomena? I don't know. I mean, but there is some people are still advocating that just on its own to correct the flat foot deformity. I think the jury, I mean, we still don't know whether that is the only thing you can do and get away with it, or whether I've removed, like I said, a few of them, but we don't know whether it is as well tolerated in the kids or not. I don't know.
Okay. So even I haven't used it in too many patients. So this patient I had done sometime in the month of September only. So I've been following him up. So he has, so this is what he looked like operatively. Okay, and that's the Siam pictures, and that's what he was looking like operatively also. So thought maybe we were able to restore most of the things that he was actually looking for, and that's the X-ray. So you can see that the navicular is well right there.
Yeah, Ajay, what you should have shown me was an X-ray after you did the calculum osteotomy only, and then you should have showed me an X-ray with the nut.
With the stent inside.
You call it stent, I call it nut.
It's a stent.
So anyway.
Stent. Okay.
Sir, can I add so if you want to restore the arch, do you think lateral column lengthening is the best thing, or this subtalar arthrodesis? You think lateral column lengthening will restore the arch better than this, I guess? Sir is probably trying to restore the arch by doing this.
Okay, I mean, that's Aditya. It's a good question. So, but we don't know whether there was uncoverage in the first place. Ajay is still hiding that X-ray.
No, it was there. I don't know, somehow. It definitely was uncovered. Okay, it was
I
uncovered.
can't
So
tell
that's the
you
reason.
whether it's necessary or not. So let's believe Ajay. He said, there was uncoverage. There was uncoverage on the pre-op X-ray. He doesn't have it, but maybe lost. But there was uncoverage. I can tell you something.
Can you show the final clinical pictures of the patient standing and
Oh
walking?
yes, of course. So this is when he had come for at 6 weeks. So before we started him with full weight bearing ambulation, this was just prior to that I had seen him. So this is what he was looking like. Okay, so then when he came back, this is what he was looking like. And when he came back, this was his X-rays. Okay, and when he came back at 3 months, this is what he was like. So he was quite confident of walking barefoot. That's how he was. Okay, you can see that all the hind foot alignment, everything had come back, and this is what he was able to perform. This is at 3 months.
Is he trying to do a single raise on that side or not?
No, I didn't tell him to do it still, but because I said at least stand on one leg and show it. So that's what he could.
So he's
I
able
didn't
to
ask him.
Yeah,
I didn't ask him to perform a single raise. Maybe 6 months when he comes in the month next month in March when he comes in, I'll ask him to do a single raise also, and I'll definitely share. And I'll definitely share the images with you, sir.
Sure.
So, Professor Panchbhavi, my question is: Would the single raise heel not be the ultimate test of the success of the procedure done by the surgeon?
Yeah, I think if you want to restore the function, that's what you should be able to do. That's what locks the Chopard joint, right? That's what makes the foot rigid for a push-off. That's the ultimate thing you need to do. Let me go back to what Aditya was mentioning.
Yeah.
We think about lateral column lengthening to restore the talonavicular coverage, right?
Yeah.
Yes, right? You said that, right? And
Yeah,
should we do Evans osteotomy? That's a great question. I'm going to save it for our live meeting in Kolkata in August. See, so I can show you a technique just by doing a particular way of doing calculum osteotomy just medial displacement calculation, but you have to do it in certain way to solve those two problems.
Right.
Not just the medial hindfoot alignment, but also the talonavicular coverage. I'm going to show you folks, I think there's a video being planned, the technique, exact technique, how to do that to achieve two things. I'm going to save it for the meeting, live meeting in Calcutta, to encourage folks to come there and increase attendance. So I'm going to show it. But that's a great question, Aditya. Over the years, I used to do the Evans in addition to the medial displacement,
Medial
but you
calculus,
can
okay.
kill two birds with one stone,
Stone.
but doing a medial displacement in a particular way. I'm going to elaborate that. I will save it for later.
Right.
Okay. So it's about it. I think this is we'll have the case from Aditya or.
I guess, I mean, the same which was telling. So you can continue, sir. I mean, we are already out of time.
Yeah.
okay.
I think you can quickly finish the second
Yeah,
case.
yeah, that's
Okay.
fine.
So
We can
this
discuss.
okay, so this is a 41-year-old lady. So she is complaining. This I've done just about last week. So I wouldn't be able to show you too many post-operative pictures and all. So this is the lady. So that's the valgus that she's got in the heel, and she's got a deformity like this, the hallux varus.
Yep.
So I had put this up in the IFAS academic group also.
Yes, I could see that. Yes.
Yes, so I was just asking what should be done for her. Should we address?
Should we address what are we talking about? What is her main problem? What's the main problem? Looks like she has some
addressing
sandals.
in her case.
That sandals she's wearing, she's not able to wear shoes, I suppose.
Hello,
Yeah,
am I audible?
Yes,
Yes.
much better, much better. Yeah, please go.
Am I
So-
audible?
Yes, you are. Yes.
Hello,
Yeah, we can hear you, Dr. Ajoy. Please go forward.
Is that Ajoy or somebody else speaking?
Hey, that's Ajoy.
Okay.
Yeah, please go on.
hello,
Yeah, we
So
can hear you, Ajoy.
what's bothering her, right?
Hello?
I mean,
yeah,
maybe
okay, but I am unable to hear. That's the reason.
No, we
Oh.
can hear you. We can hear you loud and clear.
Hello, yeah.
Right.
So Ajoy, tell us what is going on. What is her main issue? Is the main
So,
issue?
Yeah, she was complaining of
like
some
she has
pain on
some
the medial aspect of the
Okay, so
middle aspect of the heel. So this is one thing, and the other thing that she was saying that she's started developing callosities on her toes due to walking in this kind of position. So should we be addressing both the flat foot as well as the varus, or should we be addressing only one of these two?
yeah,
Both
I
at
mean,
one go.
this is a scenario which is very common in India, but hardly ever see abroad. This is really. I mean, you guys should come up with solutions for this. I mean, you are the leaders in this area, this hallux varus. You see, I don't think anybody else has that much experience as folks from India. It looks like she's obviously having some open sandals over there. She probably is not able to wear shoes and things like that. So,
Yeah.
but if it's not painful, it's just the callus. But she's able to live with that and continue wearing the shoes. Then I think we should focus our attention on what is actually bringing her to you. If the hind foot was not causing her problem, would she come to you? That's what my question would be. So,
Okay, so this is exactly where she was having the pain, and I had actually seen her 2 years prior to this visit when she had come in, and at that time she had got a very flexible kind of a plesplinus as well as a flexible kind of a hallux varus. So within 2 years, she has deteriorated to this stage wherein this is totally uncorrectable. So I'll show you the X-rays. It is dislocated. The MTP joint is dislocated, and she's got plesplinus. I'll show you this is her walking video. This is the difficulty with which she walks.
wow.
I guess it's a very complex problem. It's not just a problem of flat foot,
Plesplinus alone.
problem of the hallux varus.
Okay, so it's a combination of the two.
Yeah.
Okay,
Yes.
so these are our X-rays. Now, if you are looking at this X-ray, so this is what it was showing. So the
Oh.
talus is completely declined there.
Yes.
The calcaneal pitch is reduced, and the first MTP, you can see this is completely dislocated.
Yeah.
Yeah.
It's dislocated. So these are the tracings which I was able to make. So the this is it's a negative Mary's angle. So about 15 degrees, there's a declination. It's minus 15.4 degrees. And the calcaneal pitch also is around 17 degrees. And the hallux virus, which was here, so you can see that the completely dislocated joint, it was about 56 degrees. So this is the amount that was there. So I planned, and I thought I'll be addressing all of this again. So this is what I did. I was actually thinking of performing fusions on the medial side. So at least a double fusion here, a subtalar along with the talonavicular fusion, and then correcting the hallux virus. That was the plan with which I had gone in. And what I found during the thing was again this tibialis posterior, which was a little degenerate, but then it was still quite intact there. So, and this is what it was looking like. So again, the talus was lift. I could completely lift up the talus. So it was very much easy for me to lift up the talus there.
And after that, so on the lateral side, what I did was I just put in a, because I had not planned for any lateral procedure, I just used an allograft here and placed it into the sinus tarsi area like a like a bone block there. And this itself corrected the entire talonavicular joint and the whole of the alignment of the medial side of the foot. So when that was attained, and all I needed was a K wire to just pass and hold up the talonavicular joint in place. And of course, the tibialis posterior, which was here, I kind of tubularized it. And end of the procedure, after I had performed the MTP fusion, so this is what she was looking like. The arch is very well restored, and the toe is also completely corrected. And those are post-operative X-rays. You can see that this is very well restored. It's almost like a near normal, just about a 3 degrees kind of a angle there. And the lateral view also, you can see this was restored. You can see the talonavicular joint is well aligned. The talar declination and all has been settled. So it is almost like it's a single straight line. And the calcaneal pitch has increased to about 21.6 degrees, almost 22 degrees.
So basically, you did the
So
nut job, right? I mean, you could have done a sinus tarsi implant and got away with it, no? Is that what you did, Ajoy? Sinus tarsi implant?
Yes, sir. I didn't use an implant in her case, so I didn't have one on the table. I had not planned for it. So what I did was I just used a bone graft and I plugged it in, just tried to hold it up in place. So I don't know.
Okay. And
It's just about
that's,
huh?
that's in the sinus tarsi.
Yes, in the
So
sinus tarsi.
how long that bone graft is going to work? I mean,
I
I have
That's it.
to
I
resolve,
don't know.
but it cannot replace for a screw. You see.
Yes, it won't. So I don't know what's going to happen now. It was the graft which I had was a nice big chunk from TKR slice, which was there, allograft, which was I have this available for me. So I just put in a nice big chunk there. Now I haven't yet started her on weight bearing. It's too early for me now. So again at Kolkata, I'll
The hope,
definitely be able to tell you what is happening with her and
so
what
the
my
hope is
experiments
that
are
you're
leading
going
to.
to fuse the subtalar joint, right? I mean, you're either fusing the subtalar joint or the talonavicular joint. I mean, that basic, but the graft, we are trying to get the fusion there, right? I mean, that's your hope.
No, at least see in uh, if we had to fuse, then maybe here, would it work well if it was fused?
I mean, with that implant, that's what you're locking the subtalar joint in some way, right?
Hmm.
I mean, it's like
Hmm, hmm,
fusing.
hmm, hmm.
So with your bone graft, you're getting a permanent fusion. Hopefully, I mean, it's an attempt to fuse it,
Okay.
but you didn't have the whole heart to go ahead and do the fusion. I suppose you're trying to see what you can get away with.
Yes. So I don't know what I'll get away with, but then I land in trouble. I'll definitely keep you updated on that also.
Okay.
Right.
Okay.
Dr. Ajay, can I
Yes.
request
I'll unshare. I'll stop my
yeah,
share.
Dr. Aditya to
Yeah.
start his presentation because we are running out of time. We are
Yes.
we're shooting. Aditya, Dr. Aditya Somaji, are you there? Uh,
He's muted.
Yeah, he's muted. Unmute, and he's also may have. Yeah, Dr. Aditya, can you hear me? Yeah, hello, Dr. Aditya, can you hear
Yeah,
me?
yes, sir, yes, sir. I was in a little emergency.
Please share
Yeah.
your screen and we look forward to your presentation.
Yeah.
In the mean,
I'm trying to, sir.
no problem.
Just a 2 minutes job, and it's not a big
No
case.
problem. No problem at all. So in the meantime, there were certain questions regarding Dr. Ajoy's case, and Dr. Hitin Mathur was asking what the first MTP joint arthritic about your second case, Dr. Ajoy.
Yes, it was arthritic.
Okay.
The first MTP was arthritic. The whole thing, it had remained dislocated for I don't know how long. And the whole bits, I do have pictures. I didn't put them up again. But
Okay.
the entire, more than three-fourths of the joint was completely gone. Means there was no cartilage at all on that,
Yeah. Okay. Right. Thank
on
you.
the metatarsal head side. Yes.
Yes. Dr.
Uh,
Somaji, are you ready?
yes, sir. Are you able to see my screen, sir?
No, not so far.
So please continue the discussion. I'll help Aditya do it.
Yeah, sure. So, yeah, he's there already. Okay.
Yeah.
Right.
I guess you people are able to see.
Yes,
we
Yes, we
can.
can.
Yes, sir. Yeah. Just a short presentation of what I did in a case, and also know the views of sir. This is a IT professional, 22-year-old guy with a medial foot pain. He presented to me like this. He has pain since I got 2 months and all. He has severe pain. He's not able to walk and all. Of course, he has been trying all these orthotics since 1 year. These are the clinical pictures. There is a loss of arch and the foot lip is it's a flexible flat foot, too many toes, all the classical signs are there. And he's able to do the single leg heel raise with heel version. I didn't do any MRI and all, but clinically tibialis appears to be intact, but maybe a little painful and all. So these are the weight bearing X-rays. As you can see, there's a lot of uncoverage and forefoot appears to be detected. There is hallux valgus deformity. So after all this, and what I did try to do is I have done only lateral sided procedure without doing any medial side. So I want to know the views of sir. So what I did, I started with the gastroc lengthening and lateral column lengthening with a small recon plate and medial slide osteotomy with the Evans osteotomy. This is the intraoperative picture. I could able to restore the arch. These are the X-rays. You can see the talonavicular angle is restored. So these are the final pictures when he came to follow up. This is a non-operative side and this is operative side. He's pretty happy, but I didn't see him since 6 months and all. He has restored his arch and is walking well. So just wanted to know how does this work? If you don't if you don't like to do a medial side, I will do it with only lateral lengthening and medial slide. Medial slide and lateral column lengthening. So I didn't touch any medial thing. Only lateral procedure was done.
That's a great case, Aditya. So you see, basically,
Sir.
sometimes what happens, the tendon on the medial aspect is not too far advanced in the degenerative changes. You see, so you could salvage it. You could just do the medial slide, and I often explore it just to make sure that I'm not missing a tear or any problem, degenerative tendons. But I'll be surprised sometimes. This on the MRI, there's fluid around the tendon, and then possibly minimal synovitis, but the patient is in a lot of pain. But the tendon is pretty good. So all I tend to do is open and then close the sheath and close the soft tissue on the medial side. So in this scenario, probably would have been the same thing. If the patient has no symptoms after 6 months, that's why he's probably not coming, not just because of coronavirus, maybe. But if the patient is happy, that means that's what happened. So the tendon was not too far gone. It was not too far, degenerate. So you were able to salvage the tendon before it went down that road. See, so I think you got in there early. I mean, if you had MRI done, if you found out a tendon, then you feel okay. I should have then at least expose the tendon and explore the tendon and see what else I should have done it. So I think you did the calcaneal osteotomy and you did the lateral column lengthening. You restored the arch, which is pretty good. Again, we can certainly do that with just a medial slide osteotomy. I'll hold off on that, but a great job.
Yeah, there is a question on this. The question is, was forefoot attended as its hallux valgus might have pronated the foot?
Yeah. So the question is, he is happy that he didn't have any forefoot, and he's not. The forefoot is not his. I mean, he didn't have any complaints with the forefoot once I restored the arch. He's happy that I don't know why that the hallux valgus appears to be a little reduced after that. Maybe after the
it does reduce. So again, like right in the beginning of my basic talk, you see. So sometimes the pictures we've seen with the knee. There is an internal rotation of the knee, there's collapse of the arch, there's increased hallux valgus angle. So if you ask them to externally rotate the leg, the arch goes up, hallux valgus reduces. So if you lift the arch up, the hallux valgus angle will reduce.
Sure.
Yeah, so would like this would probably be a good case for a EOTTS for a stent, for a hyperacute stent. Would that be? Because I think that's what they generally recommend. If it's a flexible pes planus and which has got an arch which can be corrected. I'm sure Aditya, the arch was correctable, isn't it?
Yeah, it's correctable. Yes.
It was correctable. It was a correctable. If it was flexible arch, I think then just the insertion of that stent, and they have shown quite a few good results. And I think it's been almost 15 years, it seems, they have been doing this. And in India itself, I think people are also picking that up. I think Abhishek from Delhi also has been showing us quite a few excellent cases with that.
I think, if you can prospectively follow these kind of cases, putting a stent is a very minor procedure. You can just do it percutaneously, a tiny little incision. You call it stent. I don't like to call it a stent because it's not it's not keeping something patent like in a cardiovascular surgery. It could be a nut or bolt, whatever you call, but let's leave those names aside. But what you're doing is a subtalar bone block. This is not a new thing. It used to be done long time ago.
Exactly, like the Grace Green procedure. I think that's what exactly.
So you're creating a subtalar block, really. So you're kind of making the subtalar joint rigid in a way from inside. Now, the proponents for the calcaneal osteotomy would argue that you're going to doing the same thing, but without touching the subtalar joint. Do you understand what I'm saying? Obviously, the proof is in the pudding. So ultimately, which one does give you the final best outcomes? We don't know that. So you need to really do a randomized control studies. You could say, I've been doing for 15 years. These are my patients. They have all done well, or most of them have done well. I don't know. It's better than the alternative. You know what I mean? So if it's working in your hands and patients are not coming back to have that removed, they're better than before. That's great. So that's an easy, simple procedure. That's what goes. That's a big advantage for that arthroresis procedure.
Right.
Not arthrodesis, arthroresis procedure. So easy, quick to do, and probably less recovery from a calcaneal osteotomy.
Yeah, right. Yes, maybe a good follow-up probably would help everyone of us.
Adding a cuneiform osteotomy would have had any help or additional advantage? Cuneiform osteotomy is not very common, but do you think it should have been added?
Cuneiform osteotomy? You mean cotton osteotomy?
Cottons.
Yeah.
That's what.
Again, you see, there is a criteria. One, you should do a cotton osteotomy, right? So it's an intra-operative decision making. So once you correct the hindfoot, you need to see what's happening to the talonavicular joint. You need to see what's happening to the talofirst metatarsal angle on the lateral simulated weight bearing radiograph. So if you think more correction is needed, the first metatarsal talus angle is not lining up, you can certainly lower the first ray. So if the first ray is still dorsiflexed, that's when the exact indication for a cotton osteotomy. So if the first ray is dorsiflexed, you can bring the first ray around by doing an opening wedge in the medial cuneiform. And that can actually cause a varus force into the hind foot too, you see. So, what you do in forefoot reflects in the hind foot too. And what you do in hind foot conversely reflects in the forefoot too. So sometimes, when there's a plantar gaping, just correcting the hind foot will fix the problem in the front.
Right. There's a question from Dr. Kamal Dureja, sir, and the question is, how do you decide amount of displacement in medial calcaneus slide osteotomy? Is it a pre-op decision or intra-op decision?
That is a great question. That's a great question. That's why I was going to say, people who use that fixed stepping, that's why I like screws rather than the fixed, step down. So you can do too much. And I'll be honest to admit, I've done sometimes too much, and then I think I went too far. The way to decide is, do a good tibiocalcaneal alignment view, a perfect view, and see, if that possible, or have you done too much? So when you shift it, that's why I put K-wire, a K-wire in the calcaneus from the tuberosity across the osteotomy into the distal fragment, and do an alignment view. And, you can easily judge, have you, shifted it too far or not enough. And, certainly to make it easy for you, there are some technical tips and tricks, you can do intraoperatively. Then you can, sometimes, you want to shift more, you cannot shift more. So, you certainly need to release the soft tissues around. We can talk about it at some other stage. Achilles tendon lengthening may be done, and so on and so forth. You can actually not just shift medially, but also posteriorly, inferiorly. There's so many tricks you can do to avoid the other things you need to do. Again, more on it to follow in the IFAS 2021, Kolkata.
Right, sir. So if there aren't any more questions, I think we have overshoot this time. And thank you so much, sir. You have been very kind to us. You have been a mentor to all of us, mentor to IFAS, a guide and a friend to IFAS. And I can't really thank you enough for being here and being in the morning more than 2 hours, sir. Thank you so much. I also would thank my two panelists. And on behalf of IFAS, it is my proud privilege again to welcome you all to Kolkata. As you are rightly saying, Punjabi sir, you have many tricks up your ace, which you're going to show in IFAS Kolkata, and we all are eagerly waiting for that physical meeting to occur. Thank you so much, sir. Thank you everybody for joining in. See you all again next week, same time in the evening. Thank you so much.
Thank you again for the opportunity. I enjoyed and learned a lot from this interaction. Appreciate it very much.
Bye.
Thank you. Thank you very much, sir.